I am very excited and privileged and honored to introduce you to Dr. Edna Foa. Dr. Foa is a world-renowned expert in evidence-based treatment for PTSD and OCD, a professor of psychiatry at the University of Pennsylvania. Dr. Foa has dedicated her career to researching and developing highly effective interventions for these conditions. She is the developer of prolonged exposure therapy for PTSD and a leading force behind exposure and response prevention for OCD, approaches that have transformed the field of mental health care and set the standard for effective therapy. Dr. Foa, it's a true pleasure to have you here.
Thank you for inviting me to express my knowledge and share it with the audience.
Yeah. Can you start off by sharing, you developed prolonged exposure for post-traumatic stress disorder. What makes it an effective treatment and how does it differ from other trauma therapies?
The history of prolonged exposure, let's call it PE in short, it started I started in 1980. This was the year that PTSD was introduced into the DSM. And this introduction was very important because up to then, it's not like we didn't talk about trauma, because the field of psychiatry and psychology gives a lot of space to the notion of trauma. At one point, Freud thought that all neurotic behavior and neurotic problems stem from a traumatic experience. So we know about trauma. In the literature, in even ancient literature, there are descriptions of trauma. But the concept, the diagnostic concept, was introduced in 1980. And the good thing about it is that now it combines the manifestation of sexual problems, psychological problems after sexual assault, after combat, after accidents, and it's now in one place, is one diagnosis, which means that we don't really have to invent different treatments for different trauma. We could say if it works for manifestation after sexual abuse or rape, then it probably works for manifestation after combat or after traffic accidents, etc. So it unified the issue. And then, but we actually didn't have a treatment for trauma or a treatment for PTSD. And that's where I came to think, okay, I worked in an anxiety disorder clinic, very famous, with Wolpe, the father of behavioral therapy, being the head of this program. And that was my first job, actually, to work with him. And so I worked with anxiety disorder patients. And I thought I also worked with sexual assault. I worked with combat veterans, but I thought about them as an anxiety problem, an anxiety disorder. Now I have to think about it as PTSD. Why not adopt what I've learned works with panic disorder, with other anxiety disorder, and just adopt it to PTSD? Because PTSD also is an anxiety disorder. At the time when it was introduced into the anxiety disorder. So I said, no problem, I'm just adopting what I know about panic disorder to PTSD. And then I found that there is an issue that is not addressed in exposure therapy for anxiety disorder, and that the memory, the specific memory of the trauma, which haunts people in PTSD, and we don't have this manifestation in other anxiety disorder. Even if there were bitten by a dog and they have dog phobia. They are not haunted by memories, intrusive memories about dogs. But they avoid dogs, but they are not haunted by the memory of the event. So I said, but people with PTSD are haunted by this event, and there are intrusive thoughts that are scary to them, that are distressing, and they work very hard to try to divert their attention from thinking about the traumatic event. So it's a major symptom in PTSD, which we don't see in other anxiety disorders. So I said, what should we do with that? And then I came with the idea that we also need to do exposure to the memory. And then the exposure to the memory is an important factor and an important part of what a treatment for PTSD needs to include. And that's the innovation really of PE. So PE includes in reality, in vivo exposures, which are the same as we have for other anxiety disorders. If a person is afraid of dogs, we will expose them to dogs, nice dogs that don't bite. And if a person is avoiding situations that remind him of the trauma, or that he thinks that it's so similar to the trauma that he will be traumatized again, and he avoids them, we will do gradual exposure to those situations. And that's not an invasion. But very, very importantly is to ask the patients to actually recount the traumatic memory that haunts them the most at the time that they came to treatment, not the most that were the worst one in their life, but the one that at the time that they approached therapy, this memory haunted them the most. And we called it imaginary exposure. And usually we ask the patient to recount in their own words, describe in as details as they can what happened during the traumatic memory. Not only what they did and what the other person did but also what they felt, what they were thinking at the time, the bodily sensation at the time, the entire experience. And one time definitely was not enough. And we were thinking the reasons why we thought that imaginary exposure will work is that it helped the patient organize the traumatic memory, figuring out what really happened there, because they might have forgot the important aspect of what happened in traumatic memory in trauma. And so we want to correct by them repeatedly talking about the traumatic memory, and include there, as I said, description of what happened, but also what they felt, what they thought, the entire experience. And we found out that, yes, many times they actually realize that what they were thinking happened actually did not happen. Or when they felt guilty because they didn't save their body in combat, when they were recounting the traumatic memories, they figured out and they remembered that they were far away from their friend. And there was bombs in between, and artillery in between. And there was no way they could get to the friend. When they did realize it, they didn't feel guilty anymore. And so there was a switch from negative sensation, for negative self-report and the way they thought about themselves, to positive, or actually neutral. So that was really very helpful. And that didn't happen as quickly as when you do imaginary exposure. You can do cognitive therapy and you can working on guilt, but it was very effective to do it through the images. Also, you find out that if you talk about the trauma memory, even for 20 minutes or 30 minutes, you don't fall apart. You actually can tolerate the anxiety. And also, of course, there is habituation. You say it again and again and again, and you start to feel less and less distressed about the event. So there are, many ways in which the imaginary exposure was really a cardinal aspect of a treatment for PTSD. So I think this is the innovation. And not only you do the imaginary exposure after they finish to talk about it, to describe the trauma, you ask them some general questions. How did they feel? What did they learn? And so we process with them. Not only we do it, but we process the experience, what they took out of the experience. So we do in vivo exposure in reality, and we do imaginary exposure followed by processing. And studies found that actually the imaginary exposure alone was more effective than in vivo exposure. The combination is the best. But if you just do a study and you do just imaginary exposure, or you do just in vivo exposure, and you do the combination, imaginary was better than in vivo alone, and combination was the best. So that's kind of the innovation of P. And when I started it, 1980, and by the time we developed it and we tested it, it was like 82, 83, it takes time. I didn't want to publicize it before I have some data that it's really effective. Then people said, oh, this is really dangerous because you ask the people to repeat the, the memory and they will get worse. We
Traumatized.
did studies and we found out people do not get worse. The majority get better, but many people are after 8 to 15 sessions of PE are saying, I don't have the trauma anymore. I don't think about it anymore. I'm cured. That's 40% about. About another 40%, I'm feeling much better. And we do have, of course, our failures, every treatment. So between 10 and 20%, depending on the studies, we find even if they do better, not enough. And we're working to improve. That's kind of in general what P is and what's special about P. No other treatment asks the patient to close their eyes most of the time so they can focus and to actually tell the story for 40 minutes of what happened to them.
I have to share, I actually just was working with a client just this morning doing PE with her, and we did 7 imaginal sessions, and she doesn't have PTSD, and she's so excited.
Yeah, I think it's amazing to me when I see patients that really are miserable and have quite severe PTSD. 7 is unusual, but 8, 9,
7 just for we took a few sessions before for orienting, getting ready.
Oh, I see. So we actually take about 2 sessions to explain the patient what PE is in general, how it works in general, very general, and so that they know what they're going to and what they are accepting. And then we start. We really don't spend a lot of time preparing them
Mm.
because spending a lot of time preparing them actually helps them avoid.
Yeah.
Okay, you do another session and another session. And in the meantime, they don't get better.
Mhm.
And uh, yeah, there is possibility that they feel like they don't get better with the treatment and they drop out. So we really are limiting as much as we can, maybe 2 sessions of assessment and of introducing PE before we start. And they have to accept it because PTSD people are avoiders. This is it. The reason why they maintain the PTSD is because of avoidance. And they avoid the situation, they avoid people, they avoid a lot of things. And their life is very constrained. And then they're very busy trying to avoid thinking about the trauma.
Mm.
So the life is really controlled by the trauma. So it's really important for us to have short-term treatment
Yeah.
that works.
Yeah.
There are now 90 studies on controlled studies on PE. I don't know why, but people are now in love with PE, I mean, academics, and 90 studies. I used to know the people who are doing the studies because they were colleagues of mine. They would ask me, or they ask me to be a consultant, or I don't know the people that are doing PE anymore.
Yeah.
It's around the world and it's not in my hands. And that really, I feel, is a sign of success.
Yeah. Someone just asked me today, they saw that we're talking about this upcoming event, and they said, how can you say that therapy can be based on science? What do they do? Double blind, placebo controlled, whatever studies? And it's actually a version of that. Yes.
Yeah.
Can you explain what a controlled trial means when you're saying that there's over 90 controlled trials?
Yeah. So in control study, you first of all, you choose the patient in terms of that they have to have PTSD, that we are excluding people who are suicidal, really suicidal, not people that say, I wish I was dead because everybody says it, but that actually are haunted by suicidal thoughts or recently had a suicidal attempt, we delay the treatment. Other than that, we select the people according to criteria that we decided ahead of time. We don't want to take people who have mild PTSD. We really want to take people with severe PTSD, or at least with moderate PTSD. So that's the first thing that happened in controlled study, is the choice of the patient. Then once you have the patient in that you chose, you randomize it. You randomly, by chance, give them several treatments. So you give them PE, of course. Those were randomized to PE. And then you can give them treatment as usual, like psychodynamics, or you can give them cognitive therapy, um, a, a group that is not PE, and then you would like to give a treatment that you think wouldn't work for PTSD. For example, relaxation, right, that we don't think works, at least not working well, or you can actually not give any treatment. You give them an assessment in And then you keep in contact with them just to make sure that they are okay, but they don't get any treatment. Because let's say the treatment is short term, so you don't leave them without treatment for a long time. And maybe they are in waitlist control, we call it, for about 10, 12 weeks. And then we give them another assessment, and they are one of the controls. And then we compare the outcome. And that's a control study.
Thank you for explaining that. One thing I loved in your explanation of prolonged exposure and the history of it is that even prolonged exposure, which was developed in the 80s, so this is an older treatment, this has been around for a long time. And even that was developed as an adaptation of what we already know. I hear so often people reach out to me, or I hear people say, I've got this new treatment, and I'm always confused. Why do we have a new? We don't just make up treatments. We know what we know until now, and then we use what we know to further the field. We don't make up new things. And so I love that even this treatment that's been around a long time was developed based on what we knew at the time. You didn't just make it up.
So in the beginning, we had really 5 pages of a manual because we did it at home. But then when they decided to disseminate it, we had to write a manual so that people who are not treated by me, people who are not working with me could do it. And over the years, we actually made a lot of modifications as we learn more. For example, we thought that you need to have at least 40 minutes of imaginary exposure. We did studies and we found that 20 minutes of exposure is as good as 40 minutes. And so we now can do the treatment a shorter number of sessions than we did in the beginning. So we are continuing to improve. We are continuing to study the mechanisms, why the treatment works, and new ways to even improve the treatment is even more than it's now. I'd like the treatment to be wonderful and helpful in 5 sessions. There are so many people with PTSD, so they are not treated. So the more effective and efficient we make the treatment, the better off the field is gaining from it.
Periodically people get and see that they're like maybe insulted by things that I've said or feel offended by, and what they bring up is that I say that therapy should be time limited in terms of outcomes, not that you have to get out of therapy if you want to be there, but that you should be seeing results within a couple months, or that trauma is an event or series of events. It's not a disorder, and that we want to treat PTSD for people who are struggling with PTSD or other issues that result from traumatic events, but that we should treat them and not that you have this trauma, therefore you have to stay ill because you've went through this very terrible experience. Or is there, could you speak to these kind of to people who are
Yeah.
being invalidated or hurt or insulted for their experience?
Mhm. The word trauma, it's become entrenched in our language. Everything is a trauma. Every time you have a stress, every time you are unhappy about an event that happened, I was traumatized.
Yeah.
Yeah. So that the DSM is defining what a trauma is. It has to be a serious event. It has to be an event that you either feel that your life is in danger or that you actually view, you witness somebody else near you that have gone through an event that is life-threatening or death in combat. People dying near you, being killed, and rape. Sexual abuse actually at the DSM-5 is considered to be a traumatic event no matter how severe it is. just the fact that sexual abuse is so affecting the people's life that it is considered to be, irrespective of how severe it is, considered to be a traumatic event. So we are careful about what we call a traumatic event. It has to be serious. No, my husband told me this morning that he's going for several days to a meeting, and you felt, oh my God, and I'm staying with the baby alone and I'm traumatized. That's not a trauma. So we have to distinguish between a traumatic event and a stressful event. There are lots of events that are stressful, but are not traumatic. By Also, it's really important to remember that the majority of people who had experienced a traumatic event do not end up having PTSD. The majority of people actually recover. They don't forget that they had a trauma. It never becomes a happy experience. It's always sad and somewhat distressing, but they recover. They go back to their functioning daily life, and they're over. Among men, for example, only 10% of people that were traumatized will end up having PTSD. So it's important not to rush and give treatment to people who went through a traumatic event. Wait, they may get better. And you don't want to say to them, oh, you went through a traumatic event, and now you are a patient. Among women in the United States who had traumatic event, uh, on the long run, about 20% will have PTSD or chronic PTSD. So that's really important to remember, because people will come to a therapist immediately after traumatic event. They may. But then you say it just happened yesterday. Maybe you'll give them a little support, but don't revert them to being a patient by definition.
Yeah, what's the fallout of doing that? Because I do see that done, that therapists rush in, we want to help.
Yeah. And they have good intentions, but there is a negative side to it. A patient wanted in the wrong place, in the wrong time, and became traumatized. And that doesn't mean he's going to have chronic PTSD.
Yeah, yeah. So I guess I want to push on this point a little further because I know that I get this a lot. So if, let's say, the DSM says my trauma is invalid or not big enough to be a real trauma, but I'm suffering. My mental health is not, what am I supposed to do? What would be the best treatment choice for me?
Well, I think that it's a clinical decision. The DSM, for example, does not deal with psychological trauma. So if a person is being verbally abused continuously, often, I think that they may develop PTSD. But according to the DSM, they don't have PTSD because and I think it's a mistake, and probably at one point will be corrected. So if a person comes to you and says, my husband is verbally abusing me, but he never touches me, just insults me, and I'm terrified of him. I think about him and I think about what he does to me, and it haunts me, and I'm terrified of him, not because I'm afraid that he would hit me, but I'm afraid that he would insult me. And that's very painful. I would treat the patient. I will do emotional exposure. I will do P, even though they are not officially having PTSD. So it's a clinical decision.
Would you try to make the verbal abuse stop first?
What's the question?
Yeah, would you try to make the verbal abuse stop first before you would do the P?
You do it in any case, whether it's verbal or you want to make sure that the person is in a relatively safe place
Mhm,
before you start any treatment.
mhm.
But sometimes it's not so easy. For example, now in Israel, there is ongoing threat
Yeah.
in not every place. I wouldn't think that in Tel Aviv there is a constant threat. Somewhat, but in the Otef, in the south, in the north, there are constant. And you still need to help these people.
Yeah. I heard people ask after October 7th, how can we do, it's going to sound like a funny question, but how can we do trauma treatment if the trauma was really, if the trauma was really real? And they were referring to October 7th. And it was an interesting question to me, but I heard where the person was thinking was, is that we treat it if it's in the person's head. But if it's real, then they deserve to stay sick.
Well, it was real in any case. If they were in combat and they saw their friends dying, it's real. But it's real in the past, it's not really in the present. And that's okay. But we do, for example, in our studies in the United States, 50% of our patients, African Americans from inner city,
Hmm.
and they are living in threat. And we treat them.
Mhm.
We just help them make sure to minimize the threat. So not to go into places where they sell drugs in the street. Okay? So they minimize the ongoing threat. But they do live there. And it works. In fact, if we reduce the PTSD, they are more able to take care of themselves. They're more able to be rational about where to go and where not to go. They have a better understanding to take care of themselves. And here too, in Israel, we're saying, how can you treat PTSD when we have threat all over, ongoing threat? It's not different from living in the inner city of Philadelphia. And yes, if you live near the borders, you do need to be more careful than in where you go and what you do, and more attentive to your safety than if you live far away from the borders.
Yeah, so I think what you're bringing up is that there is real danger in the world, and we do have to be careful about real danger. But PTSD isn't
Mhm.
about real danger. PTSD is about symptoms that got stuck because of past real danger.
Exactly.
So, can you share with us? EMDR is a very popular treatment in the Frum community, in the Orthodox Jewish community. Can you share with us your thoughts on EMDR?
EMDR, unlike PE or CPT or cognitive therapy, was not developed in the academic setting. I'm a professor in University of Pennsylvania. Patty Rezik was in University of St. Louis with CPT. Tim Beck was in, in my department at University of Pennsylvania. So the treatment that we develop, by definition, are being respected in academia. EMDR was developed by Francine Shapiro, who was not in academia, and it had this kind of disadvantage. And on top of it, there is the theoretical underpinning EMDR is not accepted by people. It's a kind of a neurobiological theory that it's not accepted by experts.
Does it
So
have research to support that
no,
underpinning that
no. So that's another reason why, we're suspicious about the treatment. There also is a claim that EMDR works for everything, and there's no support for it. But I can say that there are studies showing that EMDR does work with PTSD. Maybe not as well as PE or CPT, but there are studies that showing that it works. Except that many of these studies are done by proponents of EMDR, so they are, look suspicious.
That's actually a really important point we didn't address when we talked about controlled trials. We hinted at it, but we didn't address this. The person who asked me about trials, they said double blind placebo. So we don't have that, obviously, but we do have that we want treatments to be studied not by the developers. So when you were saying it's so important that I don't even know who's doing those studies, I used to know the people, but now I don't even know the people, that's really important to the strength of the evidence. So what's the case with EMDR in terms of that?
It's useful, but I wouldn't say that PE was not accepted when I had several studies myself. It was. It's more convincing when it does by people I don't know, who don't care if PE works or doesn't work. And they get the same result that I am, because I can be blamed for being biased. It's my treatment, I want it to work. In EMDR, many of the studies are done by proponents of EMDR. So that's suspicious. Not enough studies and claims that are wrong. Yeah.
So,
EMDR does not work with everything.
yeah. Yeah. So I've seen EMDR, I've seen therapists say that they use EMDR, first of all, in a crisis, like right after a traumatic experience, being offered for certainly for anxiety disorders, for childhood disorders, for skin picking, for eating disorders, for all kinds of things.
Francine Shapiro, the originator, she's dead now, originator, claimed it worked for everything. So you're suspicious. And there is evidence that it works for PTSD. How well it works, as I said, there are reasons to want to have more studies by people who have no special interest showing that EMDR works.
Yeah. Yeah.
And that we're not there yet.
Yeah. What's the role of medication in PTSD treatment?
Medication is not great. For example, benzodiazepine, like anti-anxiety drugs, there are studies show that people get worse rather than better. But the SSRIs, the antidepressants, that is used for anxiety, reduction of anxiety, have been used with PTSD. The success is not great. If you compare studies that compare medication to PE, or showing that PE is more effective than medication. So when we do give medication, when the patient is depressed and have PTSD and is quite depressed, not just depressed moderately, but very depressed. You will give medication, but you give the medication for reduction of depression, not for the PTSD. So I think that what it's not the best treatment by itself. It's not comparable to CPT or PE.
Yeah, that
Have done studies, medication, and many other people comparing PE to medication and comparing, and we find medication to be inferior. Yes.
it always confused me because it seems to be antithetical to what we're trying to do in treatment. So if we're trying to tolerate emotions, tolerate distress, and an experience that is not non-threatening, then using a medication to reduce emotions or the intensity of our experience of emotions is confusing to me.
As I said, there is a place for medication, but only if there is comorbidity of severe depression.
Okay. Can you share with us why you're passionate about disseminating evidence-based practice?
PTSD is happens everywhere, in every country. In countries where there are wars, there is more PTSD. United States is more than Switzerland, for example, because we are in wars. It's also United States, there is more violence than in other countries. It really depends. But in any case, PTSD is worldwide happening. And especially it's happening when there is lots of violence. In Africa, in wars, or here and there, Ukraine, it's there. And so it's really important to have. And PTSD, you think that PTSD, well, it's not a psychotic disorder, so it's not schizophrenia. And so maybe it's not that severe. A person can live with it. But that's not true. PTSD is affecting the person every area of his life. In the relationship with spouse, relationship with children, work. People with PTSD tend to either don't not to work or to work in places in situations where they could do better, and the quality of life. So PTSD people are really suffering tremendously. And so it's really important. Not that it's not important to treat a dog phobia or the manifestation of PTSD is devastating for the distress that the patient had, the daily distress, and the functionality. And it's all over, it's everywhere. So that's why it's especially important to develop effective and efficient treatment for treating PTSD. It doesn't mean that if you are a dog phobic and you are afraid of dogs and it's affecting your life, it's not important to help. But being a dog phobic is usually not as devastating as having PTSD.
Yeah. Yeah. Can I ask you one? I had this idea when I interviewed Dr. Elna Yadin, and I'd love to do it with you also, if that's okay, to ask you one question in Hebrew. I don't think we're going to have too many Hebrew listeners, but I'm going to try to get the word out a little bit. So maybe if I could ask you one question in Hebrew, just like a general, what would you say to Haredi people about PTSD? Is that okay?
Because it's not good to admit that you have psychological problems in the family. So then הנטייה להסתיר PTSD או כן, psychological disorders, כן? בעולם החרדי, still abused, כן? sexually abused, כן? ילדים. וההורים ידעו ולא פנו למשטרה. בסוף איכשהו זה הגיע למשטרה, ואחד מהילדים הגיע אלינו לטיפול. וקצת, זה, כן, זה יכול להיות שזה מקרה בודד, כן, אבל זה יכול להיות גם באמת הנטייה של בעולם החרדי לא לחשוף מצבים שיגרמו לעולם החילוני להיות judgmental, כן, על מה שקורה. אני חושבת שחשוב היה לעזור בעולם החרדי, לעזור בזה בצורה שהם כן יופיעו למשטרה, הם כן, הם כן יחשפו מקרים שקורים, כדי שיוכלו לקבל עזרה, כמו שהילד שהיה אצלנו, כן, שכן קיבל עזרה, כי ההורים בסוף כן פנו למשטרה, ו... וגם באופן כללי, לקבל את העובדה שבעיות נפשיות זה לא אסון. אנחנו, כן, הפחד הוא שאם בעולם החרדי, בקומיוניטי החרדית, ידעו שיש מחלת נפש באיזו משפחה, זה יזיק לשידוך. אז כן, בעצם מזניחים את ה... את ה... את ה... את טובת הבן אדם, כן, לטובת הקומיוניטי. אבל כמו שאני אומרת, זו הכללות מצידי. אני לא בעולם החרדי, והקשר שלי לעולם החרדי הוא קיים. היו לנו פציינטים מהעולם החרדי, במיוחד OCD, יותר מ-PTSD, כן? ולמדנו מה קורה, ואנשים הגיעו אליהם.
Big topics. Okay, the mental health care, what would it be?
I think the first thing, there is no one thing. The first thing I think is diagnosis, assessment.
Yes.
We need, in order to give the correct treatment, in order to help patients, you have to diagnose them.
Yes.
And there is a lot of misdiagnosis.
Particularly in PTSD, by the way. I hear this so often.
Not just in PTSD, in OCD, in eating disorders.
People will claim that everything is because somebody went through a stressful experience, that means it's PTSD and not whatever else is presenting.
Exactly. And so assessment is really important, because without good assessment, you cannot really choose the effective treatment. And then with effective treatment, obviously, you know that I think that I'm biased against treatments that are short-term and that are evidence-based. And I think it's moving, but it's moving slowly. In academia, in academic department of psychology, for example, where CBT is being taught, you have graduates who are more likely to seek evidence-based treatment. But there are so many places where you can get a MA or a doctorate in psychology, which are not teaching at all CBT, and are teaching psychodynamic psychotherapy, that we really don't have evidence much that it works. and it's long, and it's expensive. And these people that goes to this kind of training prefer to use what they learn.
Yeah. Yeah.
And I think that this does prevent many people with seeking evidence-based treatment that are effective and efficient, but it's moving.
Yeah.
It's better than it was 20 years ago.
Yeah. And do these short-term evidence-based treatments really treat the problems, or do people really not get to the root of the issue?
I don't know what the issue is. Patient comes to me and they suffer, and they have a set of symptoms, and I address the symptoms, and their life they became happier, they became more functional, and yeah, this is what I want. Is it the root? I don't know what the root is. Good luck.
Thank
You're
you very
doing you're doing a wonderful job.
Thank you. I appreciate
Very
it.
important.
Thank you.